Welcome back to the Pelvic Health Summit. I'm your host, Hannah Matlock, and today we are here with our co-host of the Pelvic Health Summit, Dr. Allyson Shrikhande. Dr. Shrikhande is a physiatrist and founder of Pelvic Rehabilitation Medicine here in New York City. So I can't wait to interview you, and thanks for being here.
Thanks for having me, Hannah. It's great being on the other side.
I'm excited to interview you. Can you tell us about how you got started in this career?
Sure, yeah. So I was a resident in physiatry, so a rehab doctor, and I was pregnant with my first child, and I started to have issues with my sacroiliac joint and my pubic symphysis during pregnancy, and then postpartum, after a prolonged vaginal delivery, I had a lot of symptoms that I now know were pelvic floor. I had some urinary urgency, frequency, urgent incontinence, some pain with intercourse, and some bowel movement, constipation issues. And I couldn't find anyone to help me. And I went from doctor to doctor. Everything was normal, and eventually I was just offered some Percocet, and I figured there has to be a better way. So that's when I got interested in the field and started shadowing other doctors and pelvic floor PTs and really learning from the experts.
Wow, I didn't know that. So
Yeah.
Thank you for sharing. And then how did this translate into you founding Pelvic Rehabilitation Medicine, which is now one of the best pelvic pain centers in the world?
Well, physiatry itself, not many people know what we are.
Right.
So even my parents are like, what exactly do you do? So it's a small niche, but what we do is we treat the muscles, the nerves, and the joints of the pelvis. And we really give a whole body approach when we evaluate patients. So for pelvic pain, given the complex nature of it, physiatry really is a great quarterback for pelvic pain. But there's really not that many of us out there yet. So what happened was I recruited two of my friends, really. We had trained together in residency at NYU, and they were both working elsewhere. One was local in New York, so I started with her, figure she's local, maybe she'll join me, and she did. And then the other one, she was out in San Francisco, and I called her up, and I was like, you know, she has a history of endometriosis, so she started to get passionate about this herself. And I said, we're doing this. I know it's crazy. You just bought a house. I doubt you'd want to join me. She's like, I'm there. I'm coming. So that's how it started. It was really three of us from residency trying to, figure this out. So I essentially just, at that point, I've been doing it for almost 5 years. So taught them what I had known, and then we've been continuing to learn and grow. So it's been fun.
Wow, that's amazing.
Yeah.
And so today we wanted to talk specifically about a condition called Pudendal Neuralgia, which you treat a lot in your practice and you have a lot of experience treating. So can you tell us what this condition is, what are some triggers, what the symptoms present like, and how you treat it?
Sure. So pudendal neuralgia is essentially when the pudendal nerve fires when it shouldn't. And there's different levels of severity, leading from pudendal nerve entrapment, when there's actual dysfunction in the way the nerve is acting, to all the way down to just pudendal nerve irritation, where maybe it's just not firing appropriately intermittently. So there's varying levels. Some risk factors for it, one would be a vaginal delivery, and particularly when there's a prolonged delivery with vacuum or forceps, that can really put pressure on the pudendal nerve itself as the baby comes out of the canal. In addition, there can be other risk factors such as biking. We call it cyclist syndrome. So basically that repetitive microtrauma where you're putting pressure on the nerve at the bottom of your pelvis. So it's right at part of it, the end part of the nerve is right at the bottom of your pelvis around the sit bones. So biking can really be a risk factor. Others are horseback riding, repetitive falls on your coccyx. So we do see it in young teenagers who have a history of doing gymnastics or dance. And we do think it may be because from that ligament in the back of the pelvis where the pudendal nerve goes near, do not exactly solidify until at least age 15. So sometimes if you're doing these high-level competitive gymnastics or dance at a younger age, before the ligaments are secure, it could potentially irritate the pudendal nerve. So those are some risk factors. In addition, high tone pelvic floor, which is probably the most common. So a hypertonic pelvic floor, the muscles and fascia can really constrict that nerve. And so the chief complaints that people will come in to see us, the most classic is pain with sitting. So pudendal nerve is usually pain with sitting.
And where is the pain? Like, is it?
So that's a great question. I love. So it's in the distribution of the pudendal nerve itself. So the main would be for men. It would be you could be in the testicles and the penis. For women, it could be in the vulva or in the vaginal area. For male and females, it will be in the perineum, and then it can go posteriorly to the rectum. So we call it in the pelvic floor sling almost. And sometimes it often radiates. A common spot for it to radiate is really the medial thigh. So it can start to radiate, particularly if it's been there for a long period of time. The zone or the expansion of the dermatome can get larger if it's been there for a while.
And can pudendal neuralgia cause both in men and women sexual dysfunction, like erectile dysfunction in men and painful intercourse in women?
It can, and almost always is involved with both those symptoms. So when patients have those symptoms, the pudendal nerve is almost always involved. So yes, it can cause pain during erection or ejaculation or orgasm, and actually a common one is post. Almost equally, as if not more common, patients will say, I'm sore post-intercourse. And that's still the pudendal nerve and muscles of the pelvic floor kind of working, and whenever it's worked, things can flare. So,
interesting.
Yeah.
And so the big question is, how do you treat this?
Yeah, it can be challenging. Mm-hmm. Again, a lot of it is the severity of what's going on. So first, we would evaluate the patient and evaluate any sensory loss and see. In addition, you can do some imaging. MR neurography is usually the best imaging to really get small slices to evaluate the nerve along its distribution. And also for treatment, we usually start with protecting the nerve. It's all about stop compressing it, get more blood flow, create space so the nerve can heal itself. So everything we're doing is really making the environment around the nerve better. We can't heal the nerve ourselves, but we can make the environment nice so there's more blood flow, less inflammation, and then eventually things start to be happy and it works. So we start with a cushion. We always recommend that when people are sitting, they sit on a special cushion. Common ones that we do use are TheraSeat or cushion your assets. People always like that one because it's easy to remember. But the idea is to just relieve pressure and increase blood flow while patients are sitting. Pelvic floor physical therapy is a great place to start. So if we see a patient and they haven't tried that, we start there. We'll send to pelvic floor physical therapy, and what they'll do again is trying to any muscle spasm around the nerve, they'll alleviate that, or fascial restrictions around the nerve, whether it's scar tissue or just from chronic guarding. They do nerve gliding just to create space and make sure the mechanics of the lumbar sacral and hip region and sacroiliac joint are good, really to open up the pelvis. And again, it's all about just creating space and letting the nerve heal. And then if that doesn't work, there are other things that we can do. Medication-wise, if they do have a spastic pelvic floor or hypertonic pelvic floor, we'll usually give something called a Valium suppository to help release that tension in the muscles of the pelvic floor. We also can use what we call central nervous system neuromodulators, because when you do have this pudendal neuralgia, so essentially the pudendal nerve is firing when it shouldn't fire, right? So with that, you do get this upregulation of the central nervous system as well, because it goes to the spinal cord in the brain so many times, and it just turns up that internal volume. And we call that central sensitization. So some of the CNS neuromodulators really do help with pudendal neuralgia. We have the membrane stabilizers, which work on the descending inhibition, and then we also have the antidepressant options. But both of them are working on calming down hyperactive nerves. So in this case, it would be pudendal neuralgia. And if there is associated vulvodynia, sometimes there are topical cream options as well. And in addition, if the pelvic floor physical therapy, along with sometimes acupuncture or yoga, sometimes we'll add craniosacral to that, and warm baths, if all that doesn't really progress as we would like after about 8 to 12 weeks or about 3 months, then we'll add the protocol that we do. And the protocol that we do really is external ultrasound guided hydrodissection technique, nerve blocks of the pudendal nerve and its branches, combined with trigger point injections to the myofascial area in the sling of the pelvic floor. The idea is really to reset the muscles if they're clamped down, and to increase blood flow and space around the nerve, and then decrease any inflammation. Because we do know with all pelvic pain, there is this inflammatory response. We want to chill out the inflammation. And so that's what we're doing, is just creating space, creating environment so that the nerve can heal itself.
It's amazing. And what kind of success do you see throughout all of these different treatments that you employ?
Yeah, no, that's a great question. I mean, the protocol that we do, we're studying it, and at this point, what we're seeing is about anywhere from 60 to 70% of the people are showing improvement. So improvement in this world is, yeah, no, it's great. We're really excited about it. Improvement in this world is really about a pendulum. I always explain to patients. So if you come in here at an 8 or a 9, we're trying to, we want to get you to a 2 or a 1 or whatever we can get you. Sometimes 0, sometimes not. Really, every patient's so different.
Right.
And then at that point, we really always tell our patients, we love you, but we don't really want to see you again if we don't have to. So it's a lot of education on, you may have a bit of a flare. Maybe you sat too long on an airplane. That's common for pudendal neuralgia patients. Or you ate something really bad that caused bowel, because the bowels and GI and constipation are kind of the enemy of the pelvic floor and the pudendal nerve. So that could flare you. But if it's okay, take a warm bath, do all the stretches that we've reviewed, do the yoga. If you need a Valium suppository, take it, do your deep breathing. And a lot of times patients do very well on their own because they're taught what to do, or check in with your pelvic floor PT. But that's really what we're trying to do, is improve quality of life and keep everybody having intercourse and exercising and going to work and enjoying their social life, because it's so important.
And a lot of the work you do, as you've explained, is educating the patients and providing them with the tools and the resources to manage the pain on their, to eventually have no pain, but while they do have it, to have the tools, as you said, to manage it so that they don't need to come into the office all the time. And
exactly. Yeah, it's a lot of educating and self-care, and it does depend on the primary reason for it. But we're seeing great results, and the pudendal nerve can heal. It just does take some time, but it really can. Nerves heal, they really do. So I want to just make sure it's a message of hope out there.
Thank you.
Yeah.
And for people listening who don't have access to the work that you do in your office in New York, what can you kind of tell them to guide them in the right direction?
So we are expanding. At this point, we are expanding to...
Congratulations.
Thank you. Yeah, we're expanding to New Jersey, Bergen County, New Jersey, as well as to Miami and Washington, D.C., Bethesda area.
Amazing.
So we're in Long Island as well. So we'll be out in the Long Island area as well now. So yeah, we're really excited, and we're really excited to get physiatry out there to help treat male and female pelvic pain. And our perspective on it, I think, is fairly unique. And we're excited to work with all the other specialists in the areas and help get these people better.
It's amazing, and the work that you do is so necessary and has really changed so many patients' lives, as you see every day. So it makes me happy to hear that you guys are able to expand and bring this care to more people who need it and who are really suffering.
Yeah, thank you. Mm-hmm. Thank you.
Thank
yeah.
you.
Yeah.
And is there any advice that you have for the audience in terms of their healing, and if they're having trouble finding the right care, being properly diagnosed, and hopefully they'll be able to go to one of the new locations, but if they can't, a last word of advice that you can give?
Yeah, definitely be your own advocate and know your own body. And also, I do think that if there is a certain physician that you want to speak with outside of your realm. A lot of physicians can speak on the phone. And also, if there's a certain technique or procedure that you want, don't be afraid to ask for it. So I have some patients who come from India, and they went back to India and then got the procedure. They just had to ask, I really need this nerve block here, or I need this ganglion impar, or I need this surgery for my endometriosis. And once you speak up, people tend to listen.
That's really great advice, because I think that many people just assume that the doctor will tell them what the doctor does and what they need, but a lot of times it comes from the patient's research and the patient asking for what they need.
Right. It's so key. It's so key to be your own advocate. And again, there are multiple people, I know in the United States, Canada, other places in Europe that do specialize in this. So don't hesitate to reach out and give people a call. And everyone's happy to talk to you and try to point you in the right direction, even if it's just a phone call.
So as a physiatrist, where do you see the work that you do and pelvic rehabilitation medicine's role fit into the pelvic health care team?
Great question. Yeah. So we see ourselves as the quarterback, essentially. So as I alluded to earlier, when we see a patient, we definitely take the whole body into consideration. That's really the physiatry way. So we really would like to see the patient as early as possible, really, because it's easier for us to get patients better, and see them first, and then really initiate a proper pelvic floor physical therapy. But it's nice because we can write a proper script to physical therapy if we think there's concomitant hip pathology or concomitant sacroiliac joint dysfunction or lumbosacral issues. We'd like to add that, and then ask, maybe we want ultrasound or a TENS unit, which we can give a script for. So it's nice to see them first, write their physical therapy script, and kind of be in close contact with the physical therapists, who are always fantastic. And also, we like to see, okay, what is the cause? We always look at ourselves as detectives, really. What is the underlying cause here? And again, every patient's journey is totally different, but sometimes it's GI, or sometimes it will be an underlying bladder issue, or gynecological, or pure musculoskeletal, honestly, a high-level athlete. So we like to try and decipher the cause. So we're the detective behind it, and then build our care team. Hardly ever really never can we get a patient better on our own, but we'd like to kind of decide who else can help us, and we don't want to send the patient around to too many doctors, so we really are trying to narrow it down. So we love to see them first, see if we need to bring in other specialists in the pelvic pain realm, and then write a proper physical therapy script for not just pelvic floor dysfunction, but anything else that's going on as well. So that's how we see ourselves, as both quasi quarterback and underlying detectives.
Amazing. Thank you.
Yeah, thanks.
So as you expand, are you planning on adding any other specialties into your practice besides physiatry?
Yes. One aspect of care that we think is extremely important is cognitive behavioral therapy in combination with a mindfulness technique, then sometimes some trauma. So we are looking to do a telemedicine platform, and we'll have a psychologist on our team to really help downregulate patient's central nervous system, reiterate mindfulness and breathing, and some cognitive behavioral therapy for our patients. So
That's amazing.
Yeah, we're really excited about that because we really see it help so much. And in addition, we are also going to, we currently have urology, and at this point, urology will be in Long Island and New York City, and we'll see. We aren't expanding it beyond those borders yet, but there really is such crosstalk between the muscles of the pelvic floor, which are in the nerves of the pelvic floor, and the bladder. Because in the pelvis, there's this strange thing called cross-sensitization, and it's just a fancy word for really all the structures in your pelvis talk to one another. So if one structure is not doing well, whether it be your bladder, your uterus, your colon, then the surrounding structures through the spinal cord start to get upregulated themselves. So because of that, we feel having a urologist in-house, and particularly one that really gets pelvic pain, is beyond helpful, because it helps once you calm down the bladder, pelvic floor muscles and nerves, which is what we do, patients really do a lot better. So it's a symbiotic relationship, and we've been really noticing that it makes such a difference to be able to work with an excellent urologist in-house.
Wonderful. Thank you.
Thanks.
Where can you be contacted?
So on Instagram, you can find my personal page at doctor, spelled out DOCTOR, .Allyson, and you can find
How do you spell Allyson?
ALLYSON. Thank you. And you can find PRM at Pelvic Rehabilitation on Instagram.
Great, thank you. And in founding PRM, Pelvic Rehabilitation Medicine, what is the overall goal that you have?
So our mission is, we feel pelvic pain is underdiagnosed, undertreated, and patients really have been ignored for so long, mostly because the workup usually is normal, and almost every day I was told to have a glass of wine, or just validating their pain. Patients often can break down into tears because they've just been holding it in for so many years. So our mission is to really get it out there that it is okay, it is real, and to really train other physiatrists to go and treat patients and really try and help this patient population. And in addition to clinically trying to help these patients, I do feel that research is super important in this field. And really, we're trying to collaborate with excellent data and clinical researchers, one being the ROSE trial, Research Outsmarts Endometriosis. So any patients willing to participate, we'd be beyond grateful. And it can be patients with a known history of endometriosis. It could be patients who are potentially going for a laparoscopic surgery to see if they have it, or it could be patients who have no symptoms at all, because we need control as well. So really anyone can participate, and we'd just be beyond grateful for that participation. And in addition, we are also doing research on an IRB approved protocol through the Feinstein Institute, which is the protocol that I described earlier. So we're really trying to analyze it for both men and women, and try to, again, get the protocol out there. So our mission is really to serve pelvic pain patients and to get them the care that they do deserve.
Thank you so much for being here today and for sharing all of this amazing information, and for being such a large and pivotal player and part of the pelvic health community in New York and the country and globally. The work that you're doing is really needed by so many people. So as you know, you see every day with patients who come into your office, you're changing their lives, and there aren't many doctors that do what you do. So being able to expand and share this expertise is going to make a huge difference. So thank you again for what you do.
Thank you for having me.
And if you can relate to this video, please leave a comment below and share it with anyone else who you think may benefit. Thank you.